Hello, good evening, everyone. I'm speaking on behalf of Fortis Healthcare. This is the last 1 year we have been engaging with public on different forums on different topics, and it is mainly to connect with the public depending on what day it is. And today being Sickle Cell Day, we thought that let us have some of our doctors there, and we'll just discuss it because somehow sickle cell is not on the radar of a lot of people, and it is ignored. And I think so. India has a significant population of sickle cell patients. So keeping that in mind, we decided to have a session where we have some of our senior doctors from various specialties. We have Dr. Rahul Bhargav, who is very passionate about this. He is the principal director and chief of bone marrow transplant for Fortis Hospitals.
I
Then we have Dr. Shubha Prakash Sanyal, who's the director of hematology, hemato-oncology, and bone marrow transplant for Fortis Hospital, Mulund in Mumbai. And we have also Dr. Neena Bahl, senior director of obstetrics and gynecology, Fortis LAFM, EK2, New Delhi. And people wondering why we are having a gynecologist here, because this has its relevance here. But we start this discussion to find the reasons, and we'll be discussing it with. And with that, I'd like to first start off with welcome everyone, welcome Dr. Rahul Bhargav, Dr. Neena Bahl, and Danyal. And first, I'd like to ask Dr. Rahul Bhargav to give a overview of the sickle cell disease that India has. And as I mentioned in the beginning, Rahul, is that it is not on the radar of people, doctors, healthcare providers. There are some people like you who are passionate about it, but I think so it's the organization which has to come through, has to take it in a much more structured manner and reach out to the public on what to do, what not to do. So over to you, Rahul.
thank you, Vishnu sir. I mean, appropriately said. And Dr. Vishnu seems to be, and he's actually from a state which has got one of the largest population of sickle cell in the country, Odisha. And he has seen the suffering of the people. He has seen the suffering of the kids who comes with joint pains by being targeted. I mean, by being treated as juvenile rheumatoid arthritis or for something else, osteomyelitis, something else. You have seen how people comes with a chest infection and so on and so forth. The predominantly sickle cell has been into the tribal area, and that is why over past 75 years nobody has actually put in the efforts to siege the morbidity with sickle cell. There's no mortality increase at present moment of time in India, but morbidity which it causes is huge in terms of growth retardation, in terms of dropouts from the school. And that is one of the reasons in last parliamentary session, the government of India through various NGOs have worked out a modality over past 5 years where we have also been involved with Tribal Affairs Ministry along with Fortis has taken an initiative of eradication of sickle cell by 2047 by screening 7 million people across the network in India across. And so it's not an Indian problem, but it's a global problem. If you see past three presidents of US speaking about sickle cell in Afro-American population, which is huge and which is severe. So just to give you an estimate that in India, out of 100 sickle cells, 10 will be severe enough to require a transplant or they'll be a 3 to 4% mortality people suffering from sickle cell. While in African sickle cell, that goes up to 60%. There's more of a vascular complications, there's more of chest infections, there's a bone crisis, painful crisis, which comes to as recurrent blood transfusions, avascular necrosis. So if you see the length and breadth of from US to Africa to Middle East and to India, there's a large swath of population which suffers from sickle cell, and the suffering continues to go on because lack of resources, lack of understanding of the disease, early diagnosis of the disease, and a preventive strategy around this sickle cell. And that is why 19th June is commemorated as a sickle cell day, where all the stakeholders from large hospitals like us to the NGOs can combine their efforts to reach out to the last mile, whether it be in the tribal areas, in the forest areas, or places of Africa, where we believe the Fortis is in a unique situation to give a local solution for a global problem by having the network of hematologists across all Fortis network will be a milestone feature in the futures to come by. And that is why we are talking today about why sickle cell. We need to talk about sickle cell because we have seen from COVID eras that the knowledge and comprehensive communication leads to people being more aware about COVID, which was only 2 years old. So if we talk about sickle cell continuously in their local vernacular language, probably will be able to reach to the last mile and help in developing early diagnosis, treatment, and people can be brought into the mainframe by reducing their mortality and morbidity and giving them an opportunity to serve this vast nation and a great nation, India.
Thank you, Dr. Rahul. We come to Dr. Sanyal from Dr. Bulon. Dr. Sanyal was asking you is that if you could just in common man's language just explain to the public what are the symptoms and how do you diagnose sickle cell disease?
Yeah, so sickle cell disease is a very interesting disease, what Dr. Rahul told. It's a very geographical disease. So I always tell like that even India, if you put a map and in the middle of the Indian map, you draw a straight line starting from Odisha, Chhattisgarh, southern MP, and most important Maharashtra and southern Gujarat. So these are the belt, and very few local belt of the in Tamil Nadu and Kerala you can see the sickle cell disease. It is mostly common in the tribal populations, that is very important. But now the pan migration of the people, the different part of the world, different part of the country, so you can sell sickle even in the Kashmir, if you can pick up the sickle in the northeast like that. So the few things is very important about the sickle is, whenever the sickle problem happens, so there are two aspects. So one aspect is the sickle is a multi-system disorder. So most of the time, Dr. Rahul told very clearly that the children came with a joint pain. They're complaining of the pain, and that is ignored by the parents, ignored by the doctors, given some painkiller here and there. No one bothered to check the hemoglobin. No one bothered to check the hemoglobin electrophoresis. I personally feel as a hematologist or as a human being, when you are taking a bath, you have every right to know your hemoglobin, right? You want to know that what is your blood group, what is your name. So at the same time, you have every right to know your hemoglobin's name. That is very important. When we see the patients from the Nigeria comes here, they have carried a beautiful card. They say, we ask them, no, we are AA. AA means hemoglobin is normal. We are AS, that means we are sickle trait. So they are so clear about that. So that much knowledge is possible even in a country like Nigeria, Congo, like this sort of countries. Why not we can do like that? So every human being, every Indian should have a card properly, and they should know their hemoglobin electrophoresis, single test once in a lifetime, and they should know their hemoglobin structure. That is a very important thing. So when the patient complains of the joint pains, these are the very common thing. Most of the patients landed up with the pediatricians, joint pains. Sometimes they have a recurrent chest infection. They have a chest crisis. Sometimes they have a liver dysfunction, liver-related problem. So it is basically affects every organ, and the manifestation happens. So any patients when the hemoglobin is low, you should, if they have not done any hemoglobin electrophoresis by HPLC method, you should always check that test by HPLC method. To diagnose any hemoglobinopathy, single test required, nothing else, which is called HPLC. And I think it is the best forum. Dr. Nina is also there. I do a lot of obstetric gynecology, obstetric hematology meeting across the country. I see one thing is, I think, which pains me a lot. I see many senior gynecologists still is a belief if the hemoglobin is normal, then there is no need to do any hemoglobinopathy screening. I think that is a very, so I tell them very clearly, you do HIV patient, HIV screening for each ANC workup. Why not you include in each ANC workup hemoglobin electrophoresis? So I told my gynecologists who are there in my hospital, around my hospital, tell them it's mandatory, and otherwise I just jokingly tell that I can't see your patient unless and until your ANC paper should not include an HPLC report. So that is, I think, very important. This is a very preventable disease, but what Dr. Rahul told, the morbidity is a huge thing. And one of the interesting thing in our Indian sicklers, because sickle, I told, is a very geographical disease. So it is pan, like you can see the 3 pockets in the world. One is the Central African pocket, another is the Arabic pocket, another is the Indian pocket. The Indian sicklers, one way is good thing that many Indian sicklers, actually little bit, they get milder symptoms. But Dr. Rahul also told that point of time, because they are co-inherited with the alpha thalassemia carrier state, which actually prevents them to manifest as a more severe form of the sickle disease. So I think these are the very nutshell about the sickle cell issues in our country at present. And in Mulund, because we had the Maharashtra is a huge area, huge, and South Gujarat is very close to us. We see a lot of sickle crises. We see a lot of sickle chest infection. In fact, in today in my ward, there are 3 sickle patients admitted. That is a low we get. And one more thing, very painful for the many sickle patients, they are actually it's a genetic disease. Insurance company never covered them, so everything pay from their pocket. So this is another very important health harmony. I say that a lot of monetary pressure the family feels.
Thank you, Dr. Sayal. Now I would like to come to Dr. Neena. In fact, what Rahul actually mentioned in the beginning, that I belong to Orissa. During, I remember my MBBS days, and for 10 years I was a lecturer in the medical college. We used to get a lot of complications of patients who used to come for labor. So this is again, as I said in the beginning, that it is not on the radar of people. And as Dr. Sayal rightly mentioned, I think so the gynecologists, they also need to sort of, how do they get the right test done? How do they communicate with the patients? So I'd like to ask you is it important for a couple to get a blood test, genetic test done before planning a pregnancy?
So absolutely. Dr. Sanyal, here I would like to add one thing. We at Fortis La Farm in Delhi, New Delhi, we have our antenatal card and which has HPLC mentioned on it. So and before planning, if a couple comes to us before planning pregnancy, besides regular CBC, urine routine, viral markers, thyroid, sugar, we also do testing for HPLC and rubella specifically. Because obviously we know that if the patient is undiagnosed and she becomes pregnant, so without knowing the partner status, it would be difficult for us to plan what needs to be done for this patient. Especially both sickle cell trait and thalassemia trait, we should know before planning pregnancy, because in that case only we'll be able to see what is the partner status. Because if both the partners are carrying the trait, then 25% of the offspring can have major disease, which will have impact on the life of the offspring. And luckily, by testing this, by a very simple test, as you say, HPLC of both the partners, we can prevent this, because at 9 to 11 weeks of pregnancy, we can do a chorionic villus sampling, even if both partners are carrying this trait. And then we can tell the couple if they wish still to go ahead with this pregnancy, because it is very easy to terminate pregnancy with if the fetus is carrying a major disease. Yes, we are very, very careful of this. In fact, sometimes if the patient just comes when she's pregnant, then we do in the first visit only we do HPLC, and if she turns out to be having trait, then the partner is also tested.
Okay, thank you. Sayal, I'd like to come to another point to you on what are the causes and risk factors before we move to Dr. Bhargav.
So can you repeat the question, Dr. Sanyal?
Dr. Sayal, what are the causes and risk factors?
What are the causes and the risk factors?
What are the causes and risk factors? Yes, please.
What are the causes and the risk factors? Causes and risk factor for sickle cell disease. Sickle cell disease.
So sickle cell disease is a genetic disease, right? It's a monogenetic disease. There is no risk factor as such. So it's a monogenetic disease. So there is a single protein mutation happens, and that is why you get a abnormal hemoglobin, which is sickle hemoglobin. So problem happens in the sickle hemoglobin when it traverses, when the sickle RBCs traverses through the small blood vessels like the capillaries, and there is a little bit low oxygenation in the body. They changes their structure and become the clogging the small blood vessels. So you may not symptom all the time, but you are getting organ damage. So sickle causes organ damage to every part of the body, starting from the heart, lung, kidney, liver, brain, everywhere. So you can get patients of the sickle from the stroke, you can get a sickle from the cardiomyopathy, you can get all sorts of sequestration crises, from liver sequestration crisis, cholestatic crisis, panic sequestration crisis, you can get veno-occlusive disease, you can get acute chest crisis, you can get like a different type of infections also because the immune system is at fault. You can develop a lot of clotting issues like a thrombosis, because the sickle is basically a thrombotic conditions. So these are the issues always patients feels, and the different patients manifestation with a different problem. But one thing I see in a particular adult sicklers, I see that a lot of patients come with a difficulty in walking in the later part of their life, by their 40s, 50s, and they develop avascular necrosis. So one point I think is extremely important in a multi-specialty hospital like us. Other than hematology, all the other branches like gynecology, pediatricians, orthopedicians, because many times you have to take care of the very good bone and joint care for these patients. So in my hospital, that Dr. Bhosle, I always call him as the hematological orthopedicians, because he's extremely good in taking care of the sickle cry, and he's very passionate about sickle. So any sickle patient comes, he gets very excited about that. So avascular necrosis, when to manage, when to do medical therapy, when to go for the hip replacements. So these things are extremely important. So multidisciplinary care, I think, is extremely important and very important key for the sickle management. It's not a single department management like that for the entire well-being of the sickle patient, I believe.
Thank you, Dr. Sayal. Dr. Rahul, you are one of the leading doctors as far as this segment is concerned, who work very passionate about it. So the common man who's have logged in and hearing this, they'd like to know what are the complications and treatment for sickle cell disease, because as they say, na jankari nahi hai public. There's a lot of information deficit. So I think so people like you, if they enlighten the public, it will be a good way to sort of spread the message.
Thank you, Dr. Bishnu. Very important. First is knowing that there is a disease which exists called sickle cell. And more importantly, it can manifest within 2 months of delivery and 2 months at 2 months of age. What are the common things which people have to remember? And as this goes into the last mile at various places, whosoever is understanding and listening this in English can also listen to other part in Hindi as well when they go on our Fortis website, because we have got plenty of videos for the people in Hindi as well. For the rest of the people, please understand any bone pain, any recurrent chest infections, any recurrent blood transfusions, or thrombosis in pediatric age group, or limping which occurs, which can be because of the avascular necrosis, means the hip joint has gone avascular or without the blood. These are the manifestations of sickle cell. And what is the most important thing is plain and simple drug called hydroxyurea. Please, dear friends, understand hydroxyurea now the government is making available. The government of India in past 10 years had made a provision for giving you the free blood transfusions to thalassemics. They have also made a provision for giving free blood and free iron chelators to the public for thalassemia, people suffering from thalassemia, as well as a bone marrow transplant through a CSR activity, a Coal India, where they give you a 10 lakh rupees for doing a bone marrow transplant up to 12 years of age who has got a full match. So it means the government is also doing its part. And what are the treatment modalities for sickle cell? Similarly, a simple hydroxyurea. Now with this Parliament taking cognizance, our Honorable Prime Minister taking cognizance of this problem from Gujarat, and thus making this a countrywide, nationwide modality for in a mission mode, hydroxyurea will be available at the primary healthcare. And Odisha has always taken a lead, Dr. Bishnu. Kudos to you and to your state, who has always taken a lead for providing the hydroxyurea for past a decade-long story in a primary healthcare, and not only healthcare, primary healthcare, but giving them the assistance for traveling from remote villages to PHC to get hydroxyurea every month by month, so that the quality of life can be improved. What does the hydroxyurea does? It increases your HbF level, fetal hemoglobin level, thus avoiding the sickling for these patients, and thus reducing their painful crisis and chest crisis, and thus leading to less of school dropouts, less better growth, which means people can grow to their normal potential by reading well, going less to the hospital and more to the schools. Very important things. And new drugs, over past couple of years, new drugs have come over from various companies for reducing the painful crisis, and you'll be happy to know that there are 10 more drugs which are in the pipeline by various companies for, and by basic mechanism of sickling, they're able to understand how they can modulate these sickle cells so that they can modulate the thin capillaries in the body, so that there's no crisis which happens. Then comes the state-of-the-art therapy like bone marrow transplant, which again Fortis under leadership of Dr. Vishnu We are proud to be one of the largest centers for bone marrow transplant for sickle cell. And not only from India, people trying to get a transplant done, but across Africa, people come to get a bone marrow transplant done. And this is one of the largest bone marrow transplant unit, which does around 70 to 80 sickle transplants every year by year, serving these people across from as far as from West Indies to Middle East and to India. So bone marrow transplant remains a curative and not necessary full match, that you need to have a full match donor. Now half match can also be done, though the price and the costing goes up along with that. Third, the most important thing which the government of India is now venturing out and where the US has already done is the gene therapy. Dear friends, so as Dr. Sanyal said, one gene has gone missing, and that's why your cells became from a biconcave, they become a cell shape, which has led to all these problems. A simple change, one gene change in the body has led to this. Now, this gene therapy, along with the virus, we can put in the concerned gene on the virus and they can get inserted and can start producing the normal. It looks like science fiction to you right now, but to put on the table, the gene therapy from Bluebird has got approval from US FDA for sickle cell. Gene editing, this is called gene therapy or gene editing. The first gene therapy has happened for hemophilia in CMC Vellore, and many more centers in Delhi itself are trying to understand how CRISPR-Cas9 technology can help to do and obviate the need for a bone marrow transplant can only get away by doing a sickle cell gene editing or gene therapy. So future looks bright, Dr. Vishnu. That's the whole point. And the Fortis is poised at this present moment with Dr. Neena and Dr. Sanyal and Dr. Neeti down south and in Punjab to look after these hemoglobinopathies. And we are widening our net. We are not just sticking to sickle cell. It's about thalassemia. It is about aplastic anemias. It is about Punjab D. It is about the rest of the disorders which constitutes a burden on human mankind and which can be cured by bone marrow transplant. That is what we are looking at comprehensively. And in futures, like we're going to have a comprehensive hemoglobinopathy centers where all these people can get a comprehensive care under one roof, right from orthopedics to endocrinologist to gynecologist to a hematologist. So hematology is a small spoke in this big wheel. We need more Dr. Neena Bells, we need more orthopedicians, we need more Dr. Vishnus to combine hands to serve this population because there's a huge burden. And the idea is not only looking of the treatment part, but the Fortis is the only place in the country itself who's looking into a preventive aspect of these disorders. So treatment is one part which we are being trained for. But as a moral responsibility for the society, as a social responsibility towards to our nation, the biggest goal is to prevent these disorders. And that's, we personally internally think that we should be able to, district by district, we should be able to eradicate thalassemias or sickle cell, whichever the district the government gives this to us to adopt.
Thank you, Dr. Rahul. I'll come to Dr. Neena now. I think so. Two questions actually I have. One is the importance of the HPLC test, and the other thing is that should we be looking at having designated centers where patients of sickle cell should go for their delivery obstetric work? Because as our logo says that we care for good, and any patient who comes in, we should provide the best possible care. So is there merit on that? Because the reason I bring this up is that going forward, these are things, discussion that we'll have internally on how to look at it, because the best possible care has to be delivered.
Yes, first coming on to the first thing, the importance of HPLC. As Dr. Sanyal said, a very simple test, but it can give us so much of information, and actually we can, avoid abnormal pregnancies, abnormal fetuses coming into this world. There are lots and lots of progress has been made in this field, because if first is this, Dr. Bhargav said he's a small link, but he's the biggest person whom we rely on when we have a sickle cell or a thalassemic patient with us. And it is actually a teamwork where the hematologist, the intensivist, the gynecologist, obstetrician, and the blood bank department, they work together for the better outcome of the patient. So it is the team effort. So wherever there is intensivist, a hematologist, the patient should be catered in those centers and should be delivering in those centers. So there is, at Fortis, we have all that, as we all know that we've been working together for a very long time for the best outcome of these patients. And secondly, interestingly, if a patient has, by doing this test, we pick up that the patient has, say, thalassemia trait or sickle cell trait. And then when we do the HPLC of the partner and we realize that both of them are carrying the trait, so now we are stuck. What do we do? Either the patient tries on her own, becomes pregnant, and at 9 to 11 weeks, we do a chorionic villus sampling and find out that the fetus is abnormal. We abort that fetus. Rest 75% will be normal, because if they're carrying a trait, as Dr. Bhargav said, they are going to lead a life which may have morbidity but not mortality. But with major problem, the mortality rate is very high. So now we have progressed to a point where if we go in for IVF in these patients, then we form the embryos and then we do PGD test, the prenatal genetic diagnosis. And in the embryo stage only, we come to know. Recently, I had a patient who was not sickle cell but thalassemia trait, trying many times, but now she has just delivered a baby girl. This girl went in for IVF, a prenatal genetic diagnosis was done, and the healthy embryo was then transferred back into her womb, and she delivered a normal child. So before even the fetus goes into the womb, we can pick up this deadly morbid and mortal, which can cause mortality also, this disease. That is the importance of doing a simple test as HPLC.
Yeah, thank you, Nina. And Rahul, I'd like to ask you a few things. In fact, while we look at what is the living with sickle cell disease and the lifestyle modification, one thing which has not caught the attention of all of us across the healthcare sector is our emergency department, our ER and casualty. Because if you look at the US data, because India we don't have this data, but in US, in every year, there's at least 3 visits to the ED, the emergency department. And they have, a lot of them are attended there with painkillers and counseling and all that, and then what will be a basic investigation required. So I think so. We'll use this forum to sort of look at what are the things that we need to do going forward as far as the emergency department is concerned, because we are putting a lot of focus on our emergency department, PAN Fortis. That's one part of it. The other thing which I wanted to ask was to live with sickle cell disease, what are the lifestyle modifications that need to be in place?
So the simplest answer for the first question is, Dr. Bishnu, is that we are mostly in urban areas. And I say, when I say urban areas, the moment we move on to Chhattisgarh, and soon we'll move on to Chhattisgarh, Madhya Pradesh, Bihar, Gujarat, and Maharashtra, as Sanyal is working, their ED department needs to think about one of the causes for stroke being a sickle cell. Just not stroke is atherosclerotic, but they need to think about sickle cell as one of the causes. Their orthopedician needs to be trained to think about avascular necrosis. So if I'm being only trained in Delhi and I move to Maharashtra or Nagpur or Vidarbha area, then I cannot survive without knowing the local geospatial problems which one has. So I think the more important is, as majority of our sicklers comes from Maharashtra area, Dr. Sanyal needs to develop a strong ED department as one of the differential diagnoses to know is the sickle cell, and they can just present as pneumonia or bony pains or avascular necrosis or stroke or recurrent blood transfusion or even priapism. For that matter, the urologist might be thinking about high counts and so on and so forth, but one of the 3 to 5% people can just present with priapism for the first time. So I think the more we move on to the tribal areas, the more we open up hospitals, Dr. Bishnu, as Fortis has got a huge huge ventures lying in front of them in the future. I think it's very, very important. These geological specific diseases needs to be kept in mind while developing the ED departments, and the emergency doctor needs to be updated about these disorders so that they can be tackled at best and at the appropriate time. One is that. And second most important thing is living with sickle cell, is knowing what is sickle cell. How can I reduce my crisis? Simpler. Take hydroxyurea. Need not go into the myths about hydroxyurea, that it can cause cancer, it can cause infertility, and so on and so forth. It is absolutely safe. So from 2 months of age to say 40 years, of your age, you can take hydroxyurea without developing a sickle cell. And you kids has shown for 20 years that you don't develop secondary malignancy. So please forget, everybody who's listening today, please forget that hydroxyurea is an unsafe drug. It's a safe drug. You can take it safely. One. Second, how I reduces my painful crisis or say my chest infections by getting a penicillin prophylaxis. Simple as that, a popping pill for 21 years age because your spleen is gone. So up to 21 years of age, you can take a pill of penicillin and you can protect yourself. Third, get your vaccination done. And you know, Dr. Vishnu, the Fortis is banking upon and launching the major adult immunization and the vaccination drives in the country for the first time, and is the only hospital at this present moment in time who has taken a lead about adult immunization. So we need to make people aware about pneumococcal vaccines, influenza vaccines, meningococcal vaccines, so that they can prevent these infections and thus precipitating the crisis as well as the chest crisis and then dropping out from the school. Third most important things, avoid alcohol, avoid any strenuous activities, avoid dehydration. That's the most important. And more important thing, avoid any infections. So the more importantly, any infection you develop, you land up with a painful crisis. And avoid NSAIDs. That's called non-steroidal anti-inflammatory drugs, which are like diclofenac, brufen, or nimesulide, because that can hurt your kidneys. So living with a sickle cell is a very, very precautious thing which you live, but not a very hard and fast way of living things. Okay, you can live your life normally with some precautions, not extra precautions, some precautions, and you can live your life normally. And every sickle is not severe. There will be sicklers, 90% sicklers will not be severe, but that 10% who suffers, who really suffers, they do land up into hospitals. And Dr. Vishnu, we don't have the data, but believe me, the most important thing, if you see you pick up from Jharkhand, people do get admitted 5 to 6 times in a year. They do get admitted. And if you go to places like Kuti and you pick up the records, people do get admitted for these chest crisis or infections crisis often. And that is one of the reasons they drop out from the school. And that's why that poverty cycle never gets broken in these tribal areas or rural hinterlands. So I think most important thing is knowing your sickle cell, what kind of a sickle you are suffering from, adopting the strategy of hydroxyurea, embracing for bone marrow transplant early than late. Because the data shows if you do a transplant less than 12 years of age, the survival is sitting at 80-85%. The moment your age goes up, your survival starts coming down. So the thing is, it is interesting, and it's an interesting world that every sickle cell, like cardiac patient, like neurology patient, like a rheumatoid arthritis patient, like a diabetic patient, has got an equal right to live. And that will only come through by knowing and conquering your own sickle cell by virtue of knowledge. And this is what the knowledge is all about. You can live your life normally, and adopting these strategies, you can flourish in life.
Thank you, Dr. Rahul. And first, I'd like to thank all our panelists, Dr. Rahul, Dr. Neena, Dr. Sanyal, for an excellent exposition of what to do, what not to do, and some of the take-home points. Obviously,
can I add one point? Just one point I can add. Yeah. So one of the very most important thing in the sickle management is the constant talking with the patient and the build their confidence. And they need a lot of psychosocial support. So just today morning, one patient admitted in the sickle crisis. He's an education department senior officer, not gone to any doctors for the last 5.5 years. I asked the reason why. Well, I lost interest in my life. She's 38 years old. She had 2 kids. Husband is telling, I tried to mobilize her. She never interested to do that. Last 3 months back, she lost her sister from the sickle cell disease. So you have to talk a lot of times, and hydroxyurea is definitely very, very important. But a simple thing like folic acid, calcium supplement, vitamin D3 supplement, ecosprin supplement, this supportive care and the regular checkup, yearly checkup, this actually helps lot of things to do, so that sickle burden has come down for the particular group of patients.
Yeah, thank you, Dr. In fact, that's what I was mentioning, is that Dr. Rahul was mentioning, communicating to the public. And I think so we need to start communicating into Bharat. It is what we are communicating is in India. It's in the metropolis. So how do we, and the present government, the central government, state governments, they are very receptive to taking good ideas there. So I think so. Let's work on this. This is something very important that we have in mind. The various treatment modalities have come in, which Fortis is privileged to have them in place. So I think so. We need to communicate better and do this. And on the obstetric part, I think so. There's a huge burden which we tend to ignore our female population, and that is pan India. So, Dr. Nina, I'll just I'm being honest about it. So, I think so. This is something that we need to sort of look at. How do we sort of communicate what to do, what not to do, and sort of work on it. And Rahul, I think so. I'll touch base with you on the ED piece. I think so. That's something with you, Sanyal, and we have some very good ED physicians. But we need some technical inputs on having a proper SOP on what to do when patients come to ED, because they will keep coming. And what are the basic couple of steps that need to be done? 70-80% of them don't require admissions, but immediate care, counseling, and keeping in touch with them after they leave the hospital. I think these are some things that we have to reach out. I think so. We should come out of our comfort zone. This is something that Fortis is very keen about it. As they say, that care for the good is something that we are looking at. With that, I'd like to thank everyone for our excellent session. Thank you from Fortis. Namaskar.
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 Thank you.
Thank you.
Hello.